All right, our next session tonight is going to be Jones Fractures. We have an esteemed faculty being moderated by Dr. Porter. I do want to thank Arthrex for sponsoring this session for this hour. Dr. Porter, it's all yours.
Great. Thanks, Selene. I really appreciate it. Certainly, it's an honor for us to be here. And certainly have a very distinguished bunch of friends and orthopedic surgeons. So myself, I'm from Indianapolis. Tom Clanton, who's former president of AOFAS, is with the Stedman Clinic, and then Jonathan Smerek, one of my partners from here in Indianapolis with Forte Sports Medicine, and then Jim Flynn, who takes care of the University of Notre Dame. So we're really, really excited to be here and really looking forward to having a good discussion. We wanted to kind of make it a little more like a conversation. So I'm going to kind of just ask these guys a lot of questions and let them kind of give you the information that we want to present in a very conversational way. But I thought it'd be fun just to kind of start off with a case. So this is a case that Dr. Flynn sent to us, and I'll just let him kind of give a little bit of history. I've got some slides here, and they're just a way to, we're not going to try to explain a lot or go into a lot of detail of whys. We'll get into that in the rest of the presentation. But Jim, why don't you go ahead and take over?
Yeah, hello everyone, and thank you for inviting us to be here. A great event. So this is an 18-year-old soccer player, initially presented to an outside surgeon with an acute fracture of the proximal fifth metatarsal. Initially treated non-surgically, healed well, and went on to compete and play for about a year and a half. And then he presented to my office with acute new onset of pain in the lateral foot. These images were obtained, which showed an acute fracture of the base of the fifth metatarsal. So you see, especially here on the oblique image, some lateral sclerosis, an acute fracture line there. So I discussed with the patient his condition. I advised him on intramedullary screw fixation, and we talked a bit about the fact that this was a refracture. It had occurred once before, and so we decided to proceed with open reduction internal fixation, but also took down the sclerosis and really tried to ream that canal and place some iliac crest autograft to fill that space. And here you can see a solid screw that we placed across the fracture site, and he's gone on to heal quite well in the early postoperative period.
Great. And then here's kind of the follow-up X-rays down the road, and went back to full play. So that's what you like to see. So one of the things, let's talk about this, guys. Now, that's the golden experience from a surgeon. You know, you get the patient for the first time, even though they've maybe been treated non-operatively, and they go on to heal. They don't always, unfortunately, work that way. But we want to talk about some of those issues. And so the first thing, you know, we've been kind of challenged with talking about the Jones fracture, and I think a lot of people know basically what a Jones fracture is. But how do we decide, Tom, if it really is a Jones fracture, and are there other fractures that exist in the fifth metatarsal? So kind of what do you look for on an X-ray exam or history or whatever that kind of clues you in that this really is a Jones fracture?
I think when I see it and it's extra articular to the fifth metatarsal cuboid area, and it is not into the diaphysis itself, but at the junction. So it's diaphyseal, metaphyseal, and it's transverse or maybe slightly oblique. That's the fracture that I call a Jones fracture. Okay.
Now, would all you guys agree this would fall under the classification of a Jones fracture?
Correct.
Absolutely, yes.
Okay, I think we've all, and I'm sure our audience has too, experienced times where we've had people sent to us that were classified as a Jones fracture, and maybe on further review, maybe we weren't sure that they were, or other times people have been sent to us for non-operative treatment. And it was a fifth metatarsal fracture, but we think that maybe it wasn't a non-operative treated fracture, but really was a Jones fracture. So let's talk just a little bit about, are there other metatarsal-based fractures or fifth metatarsal fractures that are not Jones fractures? So, John, you want to just kind of maybe mention one or so that you see sometimes that sometimes can be confused?
Fractures that are proximal to the fourth and fifth proximal metatarsal articulation that almost go into the fifth TMT cuboid joint can be called Jones fractures. And of course, avulsion fractures as well that are just off the tip, and even base of the fifth metatarsal apophyseal non-union fracture fragments. So frequently that eponym is thrown around for all those fractures proximal to the metaphyseal diaphyseal junction.
Okay. But Jim, what about are there some in the shaft of the fracture? Maybe it's a little more distal. It's out of the fourth and fifth TMT of the fourth and fifth intermetatarsal articulation, but are still in the fifth metatarsal, but maybe still aren't Jones. Are there some shaft fractures that you sometimes see too?
Absolutely. We talk about dancer's fractures, more of an oblique or spiral type fracture there in the diaphysis especially. And oftentimes those are kind of rotational injuries that have a pretty classic fracture pattern. But those are, again, a little bit more distal to the classic Jones fracture.
So Tom, you want to talk a little bit about like this fracture here is obviously it is the base of the fifth, right? And but it's more proximal. And I think some people would call this more of either os vesiculaneum or apophyseal non-union. What about this fracture, looking at it radiographically, that would make you say, I don't really think this is a Jones fracture?
Well, certainly its location, and certainly that angle that you see there.
Okay.
And right on the outside edge of the fifth metatarsal base. All of those things together really cue me into that.
So the fracture line kind of being in line with the long axis of the metatarsal makes you think it's more this growth plate that never healed or something like that. Okay.
Right.
And is that, would you say it's accurate? If you have to treat it operatively, you usually excise it, or do you actually try to fix it?
No, I would typically just excise that and reattach any soft tissues back to the base.
Yeah. Is the brevis commonly attached to that, or is often the brevis more distal, or what do you usually?
I think it's usually more distal
brevis
to that.
Yeah.
Okay.
Yeah.
So the brevis is down here more. And
right. And then, sometimes there's an attachment of the plantar fascia, a band of the plantar fascia attached to that.
Yeah. Okay. All right. Good. And then, okay. So John, you mentioned the avulsion fracture. So would you consider this an avulsion fracture? Is this how you classify that? Did we get it correct on this?
Yes, that's what I would classify as an avulsion fracture. Yes.
And to be a little more elaborate, like, okay, what is it about this X-ray that particularly makes you say, okay, that's an avulsion fracture, not a Jones fracture?
Because it's into the fifth TMT cuboid joint. So anything proximal to the start of the fifth TMT cuboid joint, I would call an avulsion fracture. So you're a little more proximal there. So if you find that right at the tip there, right about there.
Now, is there this seems kind of transverse, and that Tom was talking about the apophysis being more vertical. Does that kind of clue you in also, that makes you think it's more of an avulsion fracture too? So is
right. If it's transverse, right, you're thinking it's more of an acute fracture because it's too big to be an apophysis still. Yeah.
Okay. And is that something you treat operatively, or you often treat that non-operatively?
More than often, non-operatively. It usually has great metaphyseal bone that heals well vascularized, usually heals. The rare case would be if it was significantly displaced. It's centimeter or two displaced. Yes.
So if it's displaced that much, why is it displaced so much, and why does that make you more nervous?
Well, it could be the perineal brevis could be pulling on the fragment. because it's
Okay.
a little more distal than the apophyseal fragment. So
Yeah.
it could be pulling a traction force on and displacing it.
Okay. All right. So in that sense, you'd have to repair it partly to reestablish the peroneus brevis's attachment point to the foot then.
Correct.
Okay. All right. Cool. And then, Jim, you mentioned the dancer's fracture. Is this what you classify the dancer fracture? And like, what about this alignment makes you really think it's not a Jones fracture?
Well, it's an oblique fracture, spiral type
Okay.
fracture. It's distal to sort of where the fourth and fifth metatarsals come together and sometimes articulate there. So really in diaphyseal region, that's an area that's got reasonable blood supply and frequently will heal very well on its own.
Okay. So you like to treat that non-operatively too?
The vast majority of the time, I do treat this fracture non-operatively.
Okay. All right.
So
Good.
can I put in a word there?
Yeah.
When I look at that, as long as there's not dorsal or plantar angulation, I treat it non-operatively. But if there's significant dorsal or plantar angulation, I might fix that.
And is that because of the weight bearing that would shift the weight bearing to the fourth? Is that would be
Yes.
or another reason?
That's my reasoning.
Yeah. Okay. Good. Yep. All right. So let's just use this and let's see if we can say how we define it. All transverse, extra-articular, fifth metatarsal fractures, metaphyseal, metadiaphyseal to proximal diaphyseal region. So it has to be transverse. So it has to be kind of in this area, metadiaphyseal, transverse fracture to proximal diaphyseal. Does that seem reasonable as a diagnosis? Is everybody comfortable with that?
I would concur with that, absolutely.
Okay. And then here again, we see here's one that's kind of a transition fracture from avulsion. Here's one, that it kind of comes back more proximal, but really it's starting in that same metatarsal region. So I think it's just important for us to mention that some other fractures can look like Jones fractures. So tell me a little bit about the anatomy of the fifth that will play into part of the operative decision making and why maybe this doesn't heal quite as easily. So what are some things that we can say about the fifth metatarsal just from an anatomy standpoint, Tom, that kind of helps us understand why it may be more and more susceptible?
Well, I think some of it is the fixation of the ligaments and tendons to it, which stabilize it at the base significantly more. That would be one of the main things.
Yeah.
So all these areas here is with ligaments attachment. Okay.
Right. And then it's curved in two different planes, and that creates some different stresses on the fifth metatarsal that you don't see on the other metatarsals.
And will that'll have a little bit of impact on, like, if you're going to do an intermedullary screw fixation, I assume too?
Yes, it's sometimes a little challenging to get the guide pin where you want it to be if you're using a cannulated system.
Yes. So Jim, can you tell me anything more about the fifth metatarsal that might make it a little more susceptible to some difficulty healing, or more susceptible to fractures, and say some of the more complicated fractures than what would be if it's an internal fracture, one of the internal metatarsals?
So I mean, yeah, we as Tom was alluding to, especially the base is much more rigid and fixed, and as you have a more mobile diaphyseal region, that's the increased motion through there is going to make it more susceptible. And then when we talk about healing too, we also think about some of the blood supply as well, and how that impacts the potential for healing across the fifth.
Right. So it's interesting that if you look at what Jim was saying, is you've got all these ligaments across all these articulations. Then you have the peroneus tertius. Here's the peroneus brevis. You see it does attach a little more distal. So when Tom was talking about the apophyseal non-union, there's a plantar fascia attaching to it. But that vertically oriented fracture oftentimes could be actually inferior to the peroneus brevis attachment. There's some other zones of fracture they talk about. So, and then Jim mentioned, let's see. I'll go on a little more in a moment about the motion. So, John, when you see these patients and they come in, how do they usually present to you? Like, what is a kind of a typical history? And, they have a lot of pain. Do they notice pain before? What are some of the hallmarks of the history you see?
But usually you hear, especially in the athletes or the more active patients, they're going to have a little bit of antecedent aching pain in the lateral aspect of the foot. Maybe not a lot of swelling, but they have some aching in their foot. And then frequently they'll have an event. They think maybe innocuous. They step off a curb or they're playing a game and they just step wrong. And then boom, they have a sudden increase in the pain. And that may be the transition from a stress fracture to a complete fracture. So they're usually presenting with pain, not necessarily lots of swelling, but pain with weight bearing and an inability to perform their sport.
Okay. And then, so go ahead a little bit. You're talking a little bit about exam too. So what do you kind of see on exam, and does it make a difference? Like if it's a type 1, type 2, type 3, those kind of things.
Yeah. So, I mean, the stress fractures, frequently you don't see a lot of swelling on exam. Your acute fractures, like we were talking about the avulsion and even an acute Jones fracture, you're going to see swelling. Sometimes bruising. Yes. Frequently they can walk on it. Depending on their, pain tolerance, obviously, but it is painful to walk a long distance.
And it's hard for them to play on it probably, huh?
It's definitely hard to play on it, but the more chronic the fracture is,
jump on it.
Yeah. And so Tom, to talk, I mean, I don't want to spend a lot of time on this, but so why does the type 1 get more swollen and look more swollen, but a type 3, for instance, not really have as much swelling? So what is there about that's different about those fractures?
I'm not sure exactly why it affects the swelling as much, but I think it relates somewhat to the blood supply and the way the fracture tends to occur. And there's more disruption of blood supply in some areas.
Yeah. Okay. Is it possible that like a type 1, maybe there was a stress fracture and more of the bone acutely broke? Would that be something that would maybe lead to more bruising or swelling? I don't know.
Not necessarily my experience with the stress fracture. I mean, stress fractures typically haven't had a huge amount of swelling in comparison to the acute ones that I've seen.
Yeah. This is a typical classification system. I don't want to spend a lot of time on it so the type 1s, if you want to say, sometimes they have almost all of them have some component of a stress fracture. I mean, it is a stress fracture. And then you've got this kind of a little more of acute fracture through this preceding stress fracture. I think that's what John was talking about, where they had some pain beforehand, but not enough necessarily to keep them from playing, but some pain. And then they have an acute increase where they get some fracture through it. But you don't see a lot of medullary sclerosis. In a type 2, they have some prodromal symptoms also, but they have a little more sclerosis in the canal than these typical type 3s. It's almost like a frank non-union. So does the classification system matter, Tom? I mean, does it make an impact, or is it just kind of for research purposes?
I think it does matter a little bit, especially when you have the sclerosis. I think you need to stimulate the intramedullary canal a little more, make sure that you don't have a connection still on the medial side. And, that's definitely one that I would absolutely bone graft.
Hey, Jim, when you're, let's say you've got this type 2 or type 3 in particular, and you're trying to put a screw down the canal, is there any difference in what you experience when you're trying to put your guide pin? Initially, I think most all of us use some type of cannulated system, at least a drill, even if you don't put a cannulated screw. So do you experience anything intraoperatively with these different types of fractures as far as procedurally and technique wise?
So absolutely, Dave. I mean, I think especially those type 2s where you see a significant amount of intramedullary sclerosis, it is very difficult to place that opening guide wire or whatever system you use across the fracture site. And so it takes considerable effort, and you really want to check your radiographs multiple times, make sure that you like the trajectory of your guide wire as you continue to advance it. Sometimes you need to tap it with a hammer or a mallet just to get it across there a little bit. And then again, especially as Tom was mentioning, with all that sclerosis, when you see these type 2s or type 3s and you're having that, especially those type 2s, you really want to make sure that you establish that fracture all the way across. So, and this is very similar to the case I showed earlier, where even though it was a sort of refracture, it had a lot of that sclerosis. And so after we passed the guide wire, really wanted to take down that medial cortex and make sure that the thing was completely separated and then bone grafted, as Tom mentioned.
Yeah. And here's one on this type 2 here in particular. Look at this. You see it's got a little bit of metatarsus adductus to it. And so you're going to be running into this lateral, really thickened lateral cortex. And sometimes, and I think you guys have all experienced too, and I know I have, is you start to put your guide pin in, it just kind of pushes it laterally because there's so much sclerosis here on this medial cortex. So prognostically, do you think there's much difference in the types per se? I mean, if you bone graft it, do an intermedullary screw, or you think John, you think they kind of basically same similar prognosis, just some different ways you treat them from a technique standpoint?
Well, I mean, I think they prognostically do well. All of them do well if they're healed correctly operatively. I think you're going to be pushed more towards wanting to do a bone graft for the 2s and 3s.
Yeah.
Because the gross non-union. But I think overall, if you bone graft them, especially the 2s and 3s, they should do just as well prognostically long term as the 1s.
Okay, so you don't have to be scared of them. You just have to respect them a little bit and be prepared to do a little more. So you've gotten your X-rays. You've decided what type it is, and just a couple other things I wanted to just kind of touch on a little bit. Tom, you wanted to talk about on exam. Are there some things you look for on exam that particularly help you in thinking about prognosis, and anything you would add to the procedure? Maybe not with the first time case, but revision case, or just some other things you look at on the whole person.
Yes, I think you want to do a complete examination, and when you see somebody that has a cavovarus foot, that certainly seems to add to the potential. So as you see there, that and then you have to differentiate between whether it's forefoot driven or hindfoot driven or both. And so I almost always will do a Coleman block test on the patient, just as long as they can put a little bit of weight on it to see if they correct or not with the Coleman block test. As long as they correct with the Coleman block test, I typically won't do anything else other than fix the fracture. I like to also look at the alignment of the leg. If you've got somebody with genu-varum, that's certainly going to increase lateral stress in the foot. If it's significant, or if they have a tight Achilles, that can be a factor also.
Okay.
Well, just do a routine foot and ankle exam, but look at the extremity. Yeah.
Advanced imaging. John, do you do advanced imaging, not do advanced imaging? When are, we got plain x-rays, we got our diagnosis, we think we know what type it is, we think it's probably going to have surgery. Are there places for advanced imaging, or is that not very necessary? Or
I don't believe it's necessary, especially when you get a classic x-ray like you were just showing. Now, in a revision case, in a failed fracture, fixation, yes, I could see the point of a CT to demonstrate any healing. The case for an MRI may be in a case where the x-rays are normal and maybe you have an athlete in season and you want to see if they're developing a stress reaction in the fifth metatarsal. But in those acute, when you can see the fracture, I really don't think you need an MRI. And then I really don't use bone scans for this either.
Yeah. Okay. Any of the three of you use a bone? Any of the three of you have used a bone scan on a Jones fracture in the last 3 years?
I have not.
Nope.
Nope. But I used to use a lot of them. Just means I'm old.
Yeah. Yeah. So the other thing is coming up these days is, weight-bearing CTs and spec CTs and that kind of stuff. And, CTs are helpful if you have a screw in, you're trying to decide, if there's a refracture or how much healing is or things. But, Jim, what about, have you ever, I know John mentioned, at least one situation is kind of an in-season athlete. What about somebody who has a very early osteolysis on a plain x-ray and, but only minimal pain, or maybe you just saw it incidentally because they had an ankle sprain? Is there any value in MRI scan in that situation?
I mean, you could consider one to see if it's is it cold, is it light up on a T2 image? Is there significant inflammation in that bone, or is it sort of an old just a little bit of lucency, but not an acute finding, and something that's not tender. So that I think that might be one implication for an MRI, trying to see if there's any acuity to that injury.
And maybe it's kind of relegated to like elite athletes or NC high level athletes.
Yeah.
Where like the weekend warrior athlete probably not going to be something we have to get a lot of MRI scans on. Good. So again, we've got our classification. We decided we would do or do not need any kind of more advanced imaging. A lot of papers will say the current standard of care in the athlete is intermedullary screw fixation if you've chosen operative intervention. Is that an accurate statement, Tom? Is there other things that are out there that are considered? Used to be they just bone graft them only. So kind of educate us a little bit on why is that the case, and maybe a little bit of why, but is there other things that are out there that people should consider?
I think currently, especially for athletes and probably for others as well, intermedullary screw fixation is still the strongest method of treatment. It stimulates blood supply within the intermedullary canal. And so I think there are certainly times when we'll do a little more than just the intermedullary screw fixation, but that would be my go-to, would be standard treatment of a fifth metatarsal metaphyseal diaphyseal fracture.
Yeah. Okay. Jim and John, you agree with that?
100%. Yes.
Okay. Yes. All right. So
I think that there are some things we could talk about as to various changes in how we might do it, whether we would use a headed screw or not, things like that. I know there's been some work done on plates on the plantar side of the bone, which does make sense, but I never liked that, because if you had to take the plate out and take the screws out, then you've got stress risers there that concern me. Yeah.
I think we will talk a little bit about each of your screw preferences and stuff too. So that let's don't forget that, because that'd be a good idea to talk about that some more. So I know Tom talked a little bit about some of the advantages of intermedullary screw fixation, and one is the biomechanics. Do you want to talk any more about that, Jim, or say anything in more depth about that?
Yeah, I mean, as we were alluding to a little bit before, as you have significant stress across that lateral foot, and some of the more the lateral column having significantly greater amount of motion in sort of the middle and medial columns of the foot, and then but you have the base that's rigidly attached, and so that intramedullary screw really helps to provide the greatest fixation and biomechanical compression across that fracture. So I think that it's absolutely crucial for these athletes to maximize their healing.
Yeah. And then, John, anything else you want to talk about as far as, what causes these fractures not to heal and how an intermedullary screw and operative intervention impacts it?
Yeah. So, I mean, obviously one of the reasons why the fracture doesn't heal is the poor blood supply. And I usually tell patients putting an intermedullary screw in is like a tibial nail, where you're drilling in the canal to stimulate the endosteal healing inside the canal of the metatarsal, similar to a tibia. So that's stimulating the bone to say, hey, let's start healing. And then you can bone graft it for the periosteal healing. But the drilling of the screwing and putting the screw in is stimulating the bone to heal.
Yeah.
That's a great point, Jonathan. I mean, oftentimes he's even passed that drill a couple times right across that fracture site to really drum that up a little bit. I love that.
Yeah. Good. It's interesting too. I mean, I think we've probably all done it. We've also seen fractures that have been treated, and you have certain techniques you want to do and things you think are really important and the proper exact type of screw, and yet we've seen people that have had screws that have started too low and started too side and penetrated, and yet they drilled across them and they have a screw and they've healed, right? So, maybe we think we're really, really smart and we got the perfect screw and everything, but some of it really is just establishing a better vascularity, bed to it. So you guys have never done it that way, but I've had a couple. I don't know.
Oh no.
I don't think I want to show that one to anybody. And they still go on to heal. And then you do it just perfect. And then, it's like, geez, how in the world did this not heal? But if you need some of those examples, I can show you some from my life.
I think we've all experienced that, Dave.
Absolutely.
Okay, so mechanics, physiology. So just talk a little bit about bone grafting. I know we've already talked about that a little bit, but let's talk about when to be bone graft and, what is your experience? And, this is a provocative statement, make sure you know what the fracture is. We've cited that as a Jones fracture. If you can bone graft it, bone graft it. All right. I put that in. Yeah. So I used to not bone graft as many. I bone graft more of the acute ones now than I used to. Am I just being like overly aggressive with bone grafting, or it takes longer. So I really rather not do it. But what are you guys' experiences, and what are you doing? Have you changed any indications for when you bone graft them now? I think we all would bone graft the revision ones, right? We'll talk maybe.
Yes. I think we would all do that. But quite honestly, Dave, I've over the years gone to bone grafting more and more, to the point that I think I was bone grafting all of them that I saw.
Wow.
Why is that?
It doesn't take too much time, and it just gives you a little extra insurance that it's going to heal.
Yeah.
If I'm seeing any of this sclerosis, like we talked about, those those type 2, type 3s, definitely that's a big vote to do it, to go ahead and open and bone graft there. I 100% of the time in those I've gotten to doing that. After being burned a couple times, we're probably not being as aggressive there. So I haven't done every fracture yet, but the more I talk to you guys, I think I'm tempted to go that way.
But yeah, and Dave though, but I also think, there's still patient selection issues, of course, right?
Yeah.
Right.
So we say we bone graft all, but if you get a lower demand, maybe a middle-age patient, you might not do that.
Yeah.
You're worried about it in the athlete because they're placing significant stress, and even a very active, young adult. It's not an athlete, but they're doing a lot, or they have a job where they're on their feet a lot. You worry about it, but so.
Yeah, and that's right. I mean, we still have to treat the patient, right? Not just an X-ray. And
Yeah.
I have, even in the type ones, it's not very difficult to bone graft because they are a kind of acute fracture. It's pretty easy to separate that fracture apart. I did two in the last like 3 or 4 weeks, and I didn't bone graft either one of them. And they were exactly what you mentioned, as they were not competitive athletes. They still wanted fixation because they just didn't want to take so long to get them to heal with non-operative treatment. Back when I was a resident and a fellow, I think they still kind of were, the literature was encouraging them to treat non-operatively some of the type 1s still. And I think we found that to not really be true, that even the type 1s do better with operative intervention, but it depends on the patient. Very good. All right. Second, all right, now this is back to some of your points, Tom. Use the largest diameter screw that fits well. Well, I mean, that's a very definitive statement, but let's talk a little bit about screw sizes and screw types and those types of things. I just put that my most common diameter is 5.5 millimeters. Not the only diameter, it's just the most common diameter. So, Jim, what about you? What's your favorite screw?
I use a cannulated system solid screw. I put as wide a diameter as I can get to fit, and I want those in terms of length of the screw. I get the screw. I want those make sure those screw heads or screw threads, cross that fracture site and provide that compression. But the way I do it is the system I use has a cannulated drill and tap, and I use the tap, and I make sure that I feel that forefoot moving when I use the tap. So if I see a really narrow canal, I may start with a 4-5 tap, and if I feel like there's really good purchase distally, I'll go with a 4-5 screw. Most commonly, I agree, it's 5-5, but I've put even a couple 6-5s in my a couple years. Every once in a while I get somebody that the 5-5 tap. I don't think I'm going to get any purchase distally, and so you pop up to 6-0 or 6-5, and you do what you got to do. You have the options available.
Yeah. John, what's your kind of screw of choice?
Yeah. I mean, I'm with you. I'm still at 5. I haven't put a 4-5 in a long time. I try to jam those 5-5s in best I can, and I use a cannulated screw, and I make sure to countersink the head to make sure make sure you're out of the 5th TMT cuboid joint, so you don't have any screw impingement. Yeah. And I'm trying to get threads across it, not always, but trying to, and get a good diaphyseal fit of the screw, so you get a good bite.
Yeah. So, Tom, headed screw always, a headless screw. What does it make a difference? Like some of it's just surgeon preference, but kind of talk to us a little bit about that.
I think definitely in the past we were all using headed screws, and that's what I used up until I retired finally. But looking at the literature now, there's still some literature that suggests that the Herbert type screw with threads on each end works effectively. I just didn't like having to go back in and pull one of those out. But in terms of healing rates, there's a recent paper that's been published that shows that they have similar healing rates to the headed screws.
Yeah.
And then Dave,
we're about screw head impingement, right? Generally, I mean, that may not be totally true, but probably that's not a problem with the headless screw.
And Dave, one thing I would add too, Dave, is obviously most of you know this, but try not to use titanium. Not a big fan of titanium in this condition, also because frequently it can make removal in the revision case difficult.
Yeah.
So that's frequent. Why I don't use it.
Is it because it sticks to the bone because it strips easy, or both?
Yeah, it strips easy. strip easy. So then you're looking at you having to ream over it. Or just softer metal. So yeah, that's why you stay away from titanium in this fracture.
Yeah. Okay. You know, I'm with you guys. I've used 4, 5, 5, 5, and 6, 5. You know, 4, 5, and 6, 5 about the same amount. It's interesting, and I don't know. I'll get you guys' thoughts on it. The medullary canal does not always correlate to the size of the person.
Right.
Like, you got somebody really big doesn't necessarily mean their canal is as big. And I've seen some 45-year-old women who just like to play tennis, and they've got some pretty and large canals. So is that you guys' experience too, or you, what has been your experience?
Don't judge a book by its cover. Yeah.
I would say that I always tap, and I'll tap up to the area where I start feeling the tap torquing the distal bone.
Mm-hmm.
Once I get to that, that's where I'm going to end up.
Yeah. So,
hey, David, we have a question from the crowd asking the role for bioabsorbable screws. What are your thoughts on that, all of you guys?
Who wants to tackle that first? Anybody?
I personally think that's a terrible idea.
Has anybody ever used a bioabsorbable screw in this situation?
No.
No. I have not.
No.
I have not. Tom, I assume you have not.
No, never.
I don't think that there's not the rigidity. The screw doesn't have the rigidity required for this fixation.
Okay. So one, it just may not work well. Anything else, Jim, about a bioabsorbable screw that might make you a little nervous?
Well, I mean, I worry about then, if you get to the, as Jonathan was alluding to with the titanium, if it doesn't heal and you got to take it out, you're really, curetaging that whole thing out and really painstakingly trying to remove that. So you always in the back of your mind have to think about, well, if I have to revise this or this has to be redone, how is my life going to be a little less difficult? So I think that I think in that situation, I think a bioabsorbable screw, at least for right now, I haven't seen any literature to kind of push my hand that way either. So be very reluctant.
Tom, have you back? I think around the time I was a fellow, I think bioabsorbable screws were becoming really popular, maybe for like syndeses and even Liz Franks. What did you have much experience seeing patients who had some of those in? Were there problems with the screw itself? I mean, did they them or anything?
I think every once in a while, I did knee surgery also, and so in ACLs we use some bioabsorbable screws in the tunnels, and sometimes you'd see some inflammatory reaction to them, and so that was one of the reasons I just never felt like for fracture fixation I wanted to take a chance that they might not be strong enough, they might create a reaction that I didn't want to see, and so never really thought about using a bioabsorbable screw in a fifth metatarsal.
Okay. All right, good. Selene, if they have more questions on that, yell at us, okay?
I sure will.
I think we're thumbing down it at this point. That doesn't mean it won't change. Believe me, everything I've thought about Jones fractures has changed. It seems like one way or the other, but right now we have to say no. Screw head impingement. We kind of talked about that. We talked about recessing the head. We talked about headless screws. Only thing I would say is just be careful. The other is we haven't talked too much. We did a little bit on Jim's first case, but I used to not get all 3 views intraoperatively, and I got burnt once or twice on one. I wasn't getting AP views, and I'd have some that would the tip of the screw would be a little closer to that medial cortex than I really wanted, and occasionally would go penetrate through. So I think with the screw head impingements and other reasons, like get all 3 views of the image intraoperatively. Is Is that you guys' experience? You're probably more impulsive than I was but
Yeah, no, 100%. I want to make sure that on all three of those radiographs, look at that lateral really carefully. Even take a couple different obliques. You just make sure that you have no and there's no chance that head is going to be hitting up against the cuboid, because if it does, the fracture heals, and then and then what? They're still having pain there, and then where's the pain coming from? And it's a whole. Take couple extra minutes, making sure, advancing the screw another couple millimeters can go a long way. So,
yeah. Good. All right. So we're saying get 3 views in the OR, because you can change something in the OR. It's a really big pain when you find out the first post-op visit you need to change something.
Yep.
Correcting the mount. So here's another question. Tom, you've talked about this just a little bit when we talked about the exam, but do you guys do an osteotomy? When do you do an osteotomy? When do you do an osteotomy, the first metatarsal versus doing something in the heel bone? So, John, you want to talk about that a little bit?
Well, I mean, I don't have a ton of experience doing osteotomies in the acute or the non-union case. But I mean, if I had a rigid hindfoot varus, yes, a Dwyer, lateral calcaneal osteotomy is most likely indicated, and even possibly a first metatarsal closing wedge. Yeah. If it's rigid, and that's why you do your Coleman block testing, obviously.
Yeah.
And it may be even worthwhile. I mean, unless it's a revision case, you don't have to necessarily do the osteotomy, primarily, I would think, unless it's a revision,
So more in the cases that fail.
Failed, yeah.
Too, Jim, or no?
Right. Yeah. No, I agree. I reserve that for a non-union or delayed union that I'm revising. I have not done one in an acute setting yet. Doesn't mean I won't encounter that patient that's has especially significant cavus or rigid varus, but I would typically reserve that for a revision.
If you have a choice, Tom, and a little, your Coleman block test is a little equivocal. Would you rather do a first metatarsal osteotomy, or would you rather do a calcaneal osteotomy?
As long as the Coleman block test shows me that I get correction and it seems reasonable and it's a first-time fracture, I'm probably going to treat them with an orthotic device, a dropout of the first ray, and see how that does. Fortunately, I have not been burned too often on that, but I have had to go back in on one professional athlete who had a very bad cavovarus foot, and it really didn't correct much, but he had the same thing on the other side, and the other side wasn't a problem. So I decided not to do an osteotomy, and then ended up having to go back later and do it when he refractured.
Yeah. So you mentioned something that I picked up on. I want you to talk just a teeny bit more and explain. You said I use an orthotic and I use a dropout I think you said a dropout for the first metatarsal. Did I hear that right?
Yes.
Tell me mechanically why you doing a dropout of the first metatarsal.
So what that does is it relieves some of the stress on the lateral side of the foot, and it still gives you weight bearing on the first ray. That's been the reason.
So it kind of allows the foot to pronate a little bit, so it shifts the weight away from the lateral side.
Yes.
The same thing you're trying to do with a first metatarsal osteotomy, I guess, because the first metatarsal osteotomy, that's a dorsal closing wedge osteotomy, correct?
Correct.
Yes. You're lifting the first metatarsal up. So, okay.
You just have to be careful you don't lift it up too much.
Pardon?
You just have to be careful that you don't lift it up too much.
I know I did that on an offensive lineman, and he had second metatarsal pain after. His was a peroneal tendon problem, but I did a first metatarsal osteotomy, and I probably let it lay just a little bit too much, and so then I had to get him an orthotic and unload his second metatarsal. He fortunately didn't get a stress fracture, but he was wondering why his second metatarsal hurt so much. And I said, because I did a really good first metatarsal osteotomy.
David, we got two questions coming out from the crowd. One is, for the intramedullary screw, do you need to target the opposite cortex distally? Number one. And number two, have you guys seen breakage of screws in the athletes? And what do you do in those cases?
So, hey, Selene, when you say breakthrough, what do you mean? The screw actually breaks, or it's breaking through the bone?
No, when the screw actually breaks, what do you guys do?
Ah, okay. Anybody? Let's see. Jim, talk about getting the distal cortex. So I think they're talking about, like, because the bone curves and you're putting your screw down, do you try to kind of hit that medial cortex distally with the screw? How do you respond to that?
So each fifth metatarsal is different, as we found. Some have a really significant curve. Some are less, are more straight. And I think my goal is to try to really hit that, the center of that canal distally. Sometimes cheat a little bit medially, but really you don't want to. You're worried with that screw coming out. Oftentimes it comes out on the medial and sort of the plantar side, so you don't want to overshoot that medial cortex. So I really aim for the center of the canal distally. I recognize, and for those fifth metatarsals that are especially curved, I'm just trying to get the threads across the fracture. I think if I can just get the threads across the fracture, I'm happy.
Yeah. Good. The only time I would say I would look at that is I had one recently that had actually kind of angulated, and it was a more like a middle-aged woman tennis player, and I just wanted to get it reduced a little bit better, and I wasn't sure that I could get a 5.5 in, so I used the 4.5 screw. So since it was a little smaller diameter screw, I kind of wanted to get a little purchase on that medial cortex. But you're exactly right. If you're gonna penetrate on your screw, it's gonna be through the medial cortex, because I've done it. I've never penetrated any other cortex, but I've definitely penetrated the medial cortex, and you'll see it best on the AP image. You will not see it on the oblique, and you will not see it on the lateral. So that's the other reason. So, Tom,
I've been there.
I know you love to take care of all the really bad problems to veil. But they know you got better healing up in the mountains there. Tell us just a little bit about how you handle a broken screw, because that can be a nightmare.
You're exactly right about that. Fortunately, I haven't had to deal with too many of those. But basically what you do is you take out the proximal portion, and then sometimes you'll actually have to window distally and to get it out, and then bone graft it like heck, and put in a screw that engages farther into the diaphyseal area.
Yeah. That's the only time where you hope they put a cannulated screw in.
Yes.
Put a cannulated screw in, then you can take the proximal part out, and you can probably do a reverse threaded easy out, and sometimes you can get it to thread out. But
I know we've got about 4 more minutes, but I want to get this next question in. What's the role of plates for fixing the Jones fractures? It's a recent trend we're seeing, more plates being used. What do you guys think?
I know you mentioned that a little bit, Tom. Do you want to say anything about that? I can say a couple things, Tom.
Kevin Varner has been an advocate for that. And I knew Kevin well when we were in Houston and ran our fellowship together. And he's a smart guy. He's done some good research on it. He he realizes that it's on the correct side of the bone when it's put plantar. And I think you can definitely use it. And he's done some studies that have shown good healing. So I think that it's a very reasonable choice. I penetrated a medial cortex once because there was an osteophyte that I didn't recognize on the cuboid that misdirected the guide pin. And so I took the screw out and then put a plantar plate on it, and the patient did well. So I've used it one time, and that's my experience.
I've used it, I think, twice, but I used it in a little bit different application, Selene. I used it on kind of a comminuted Jones variant. So there was a Jones component, but then there was some proximal fracture into the metaphysis. So had a little bit of a crushed component to it. And I just didn't think a medullary screw would be a good idea, because I just thought it wouldn't have any kind of grab proximally. So in that situation, I did a plantar plate, and then I did one other similar to that. And actually, oddly enough, I used a small intermedullary screw in addition to a plantar plate. And I got them both on because I was a little concerned about whether the Jones portion of it might not do well long term. Do you have another question?
Yeah, one other question, and then we'll wrap up the session. Somebody's asking, in the case of a refracture, if you have metatarsus adductus, are you guys addressing the adductus as well?
You want to mention that? You want to? I'll say something about that in a second, because I just had a case just exactly like this. John?
No.
Is anybody? Here's the question: has anybody done a Bunionette correction and a Jones fracture fixation on the same bone at the same time?
No.
No.
I have not either.
No.
But that's an interesting question, though, because yesterday I did a revision on a really, really good athlete, and that's exactly why I think he refractured. And they asked me, well, shouldn't you fix that? It was a little bit opposite of that. He had an outward bowing fifth metatarsal. So on the metatarsus adductus, I haven't. But the question on the other way around is, you've got a really laterally bowing fifth metatarsal, and so the fifth metatarsal head is really prominent. And so the question in my mind was, do you do any type of additional osteotomy? I chose not to. I told him, I said, I think if we get this to heal and get it solid, the Jones fracture will do okay, even though he's got this anatomy. So I would feel the same way on a metatarsus adductus. It's a challenging problem, though, Selene, when you've got a significant metatarsus adductus and you have a Jones fracture. One, it's hard to even get your screw in. And two, it is really, really challenging, because it's, that angle you're going to has so much stress on it. Sometimes in those patients also, they end up with a fourth metatarsal Jones. So that's the thing to think about.
Cool. So I'm going to end it on that because we're running out of time, but I want to thank Arthrex for sponsoring this session and all of you guys for a scintillating conversation.
Yeah.
Thanks, guys, for being part of this and for the night.
Thanks, Selene. I appreciate it.
Thank you,
Really
guys.
honor.
Thank you so
Appreciate
much.
it.
Bye-bye.
Thanks, Selene.
Thanks, guys.